webinar. But before starting this webinar, I would like to express sorrow and grief for sad demise of our past president, Professor Subir Datto. He passed away early in the morning today. So we will have a condolence, and for 1 minute we'll pay a tribute to him, and then we will start with the webinar.
Yes,
So
madam.
we all will have for 1 minute. So now our prayers are with him, with his family. We have really missed a stalwart from our association. He was such a learned person and respected by all of us. But again, walking on their footsteps, we have to continue with the academic pursuits of the association. So I now hand over to Dr. Radotra, his today's moderator, to carry on with the proceedings of webinar further.
Thank you so much, and good evening, everyone. Today we have a interesting topic which will be discussed by Dr. Pranav Patwardhan. He is a very accomplished pathologist, and you will be glad to know that he is the master of this particular topic. He graduated from Grand Medical College, Mumbai. Then he pursued his MD, or he obtained his MD pathology from CHGS Medical College and KEM Hospital, where he underwent the senior residency program also. He was known here, and he had started taking interest in algorithm and pathology even at that time. But subsequently he moved to US, and currently he is working in Department of Pathology at the University of Pittsburgh Medical Center, USA. Uh, he was invited to write an article on algorithm in the Pathologist magazine, and the Pathologist magazine recognizes him as one of the powerful pathologists. And as I said earlier, that he has a great interest in this particular topic. So therefore, I think today's guest lecture, as it is very important and something new, he is the appropriate person to deliver this lecture. And therefore, I present to you Dr. Pranav Patwardhan for today's webinar. Thank you.
Thank you, sir.
Thank you for the
Dr.
kind
Patwardhan.
introduction. I will share my screen now and we'll get started. Okay. So can you see the screen, like the PowerPoint
Yes,
presentation
yes,
now?
yes,
Okay.
we can.
Okay.
Yes,
Good
yes.
evening
Yes.
to all in India. So it is my distinct honor to present to you this topic on the art of algorithms. This is something which I started doing when I was doing residency in India, and I've tried my little bit to make some topics in histopathology easier for understanding for medical students and trainees. I code this. Okay, so is it not moving now?
Yes.
Is the slide screen moving or is it not moving?
No,
We
no, you
didn't
can
move.
change. Yeah, it's not changing.
Yeah,
It
it's
didn't
not
change.
changing from my end, I guess. Just wait a minute. Sorry for that. Okay, now you can see the PPT without the
Yeah, yeah.
screen like
Uh,
more. Now let me try the same.
Go ahead.
Yeah, now you can see slide number two.
yes, yes,
Okay.
yes.
So I quote from what I wrote in the Pathologist magazine article that not every disease presentation is typical. Sometimes an important finding is barely captured on the edge of a slide or is buried in a relevant clinical history. Other times, an abnormality in a biopsy, it may not just lead you to a primary diagnosis, but may also lead to an unrelated second observation. So, as a trainee or as a medical student, when you have so much information to correlate, how would you try to logically progress through the steps from sample to diagnosis? And how would you try to ensure that you are taking note of every important finding along the way? This was the question that I asked myself when I started learning pathology, and this is how the thought process developed, and I tried to make some educational tools. The answer is basically simple and it will come ahead. So, to summarize what I wrote in the previous paragraph, I'm trying to answer like how could I minimize the chances of error in the diagnosis? How could I finally become a competent pathologist out of my training? And how would you ensure that you know your limitations and strengths while evaluating a slide? I believe, and the seniors may comment on it later, that gaining competency in pathology training is not just knowing the rarest of the rare tumors or neoplasms, but it comes down or it boils down to being aware of our own limitations and strengths and being aware when we need to ask for help or need to ask for a second review of what we feel. And I thought the answer lied in algorithms and checklists. So, what are our challenges as pathology residents or medical students in learning pathology in the current era? There is an increasing complexity of classification systems. Now we have frequent development of newer immunohistochemical markers and ancillary tests, and there has been a drastic shift to dependence on molecular classifications, especially in subspecialties. For example, in neuropathology, if you see the recent WHO CNS neoplasm revisions, there has been an IDH revolution, and we nowadays tend to depend more on the molecular classifications. And with this comes the increasing need to know and to learn interpretation of molecular diagnostics with routine histomorphology. Although this may not be the case in every medical school or residency training or in terms of every individual, I believe that subconsciously we have starting to give lesser importance to the morphological way of teaching pathology. There may be different views on it, but I think that the morphological findings need to be correlated with the immunohistochemical findings and the ancillary technique results for us to arrive at the most appropriate or the most definitive diagnosis for the betterment of the patient. Let us take an example of the WHO CNS tumors. On the left hand side, this is the classification of 2007, and on the right side, this is the classification from 2016. So as you might see, the way we classify astrocytomas, oligodendrogliomas, or ependymomas has drastically changed, and there has been an IDH revolution where we essentially depend on the IDH wild type or the IDH mutant type of the tumor to classify it. Now, there are some positives and negatives. The positives are, for example, if you consider the diffuse midline glioma, which is H3K27M mutant, if you go by morphology, you would think of it to be predominantly a low grade neoplasm. But because we now have definitive answers and definitive mutations which define these tumors, we know that although this looks morphologically a low grade tumor, it can behave clinically in an aggressive fashion. The downside is not every center in the world has the latest technology. Not every center can do 1p19q co-deletion studies, and in some cases, unfortunately, even the patients cannot afford it. So, what would be the golden midpoint? Because essentially, What does not change is the fact that oligodendrogliomas, most of them still have a fried egg appearance. Astrocytomas tend to have a fibrillary background, and ependymomas, most of them would show rosettes. And so would we make an attempt to try to kind of bring all these findings together to develop some sort of an algorithm or a checklist? The foundations of any algorithmic approach essentially go along the same line. This is something that we tend to follow or tend to observe consciously or subconsciously every day of our life when we try to evaluate a slide. And so it goes from the relevant clinical history. So in the relevant clinical history, it could either be the clinical presentation that may be more important in a particular organ system, or it could be the biochemistry and the biochemical results, or the cytological findings, or the radiological impression. And after that, we would move from the relevant clinical history to the gross examination, and then the hematoxylin and eosin slide evaluation, followed by immunohistochemical workup and newer techniques and molecular path. So this is essentially the workflow that we follow in evaluation of any case. The trick would lie in the fact that different factors will be relevant when we would learn or when we would try to evaluate different organ systems, and those relevant factors should find a place in the algorithm that you would try to construct. So when I say relevant clinical history, it should rather include the most important positive and negative findings, which would help us to rule in or rule out a particular lesion or a group of lesions. For example, in a CNS neoplasm case, the age at presentation and the location of the tumor would be important. The third most important thing may perhaps be the radiological impression. So essentially, before evaluating any slide of CNS neoplasm, when you know the age, the location, and the radiological findings, you would essentially be able to arrive at a narrow list of differential diagnoses before you start the microscopic evaluation. In the case of bone tumors, the age at presentation and the location of the tumor would be extremely important. In fact, it is said that you should not try to evaluate any bone tumor without having a look at the radiology. For thyroid nodules, the functionality of the thyroid in terms of thyroid hormone levels and antibody assays may give you some hints whether you're probably going to look at a functional thyroid lesion or a disease or a neoplastic lesion. In the evaluation of lymph nodes, whether it is a solitary lymph node, whether it is painful or painless, and whether other elements of the reticuloendothelial system like the liver and the spleen are enlarged, would give you useful hints along with the FNA workup if available to think of a possible lymphoma or a reactive lymph node lesion. And finally, the entire amount of information that you get from the clinical history or from the clinical presentation has to be summarized to formulate a differential diagnosis. So your goal at step one should be to basically try to arrive at a very narrow list of differential diagnosis which you would think of when you would evaluate the slide. Obviously, I understand that there may be exceptions. The tumors not necessarily follow the books, and so you have to always be ready for exceptions. But this approach might help you in in the most probable or the most common scenarios during your residency or even during your professional career later on. Let us take an example of a lateral ventricular space occupying lesion. Uh, Along with all the kind of tumors in the CNS, you would most likely want to think of three tumors which are especially common at this site. They include central neurocytomas, subependymomas, and subependymal giant cell astrocytomas. What would be the next step that would give you perhaps more hints to a probability of a particular tumor being there? It would be a family history of tuberous sclerosis. Because if you dig the history and you find that there is a history of tuberous sclerosis, your level of suspicion for the tumor to be subependymal giant cell astrocytoma would be higher than the other tumors that are common at this particular site. Now, if you would take an example of a thyroid nodule, yes, morphology most likely would tell us whether it is a goiter or whether it is a follicular adenoma or a papillary carcinoma. But having come to the US, I have been seeing ThyroSeq and other molecular tests which are being increasingly used to decide what is the ultimate fate of thyroid nodule. And as you dig deep into it, you realize that you really need to correlate a lot of things before you arrive at a particular diagnosis. So even before you would evaluate a slide, if you would know the age and the sex of the patient, like if it's a male and if it's a younger patient, you would have a high degree of suspicion for it to be neoplastic. The next step would be knowing the thyroid function, like assessing for T3, T4, and TSH levels, because what that would essentially tell you is alteration of hormone levels would suggest some functional defects and would more likely indicate to you that this could be a functional thyroid disorder than a neoplastic thyroid disorder. Having said that, there is a rare possibility that a thyroid which is kind of pathological because of some medical disease or some functional disorder may have in it a solitary thyroid nodule which may be neoplastic, and that is why the next step of radiological impression of a thyroid nodule would assume importance. If the nodule is solid, hypoechoic, and has peri and intranodular vascularity, you are going to be more suspicious of it being neoplastic, and that is why you can see here that I have drawn crisscross arrows below the level of the thyroid hormones being normal or altered. Because even if the hormone levels are altered, yes, you are thinking more likely of a functional thyroid disease. But if the ultrasound is very suggestive or suspicious of it being neoplastic, still your threshold for thinking about it to be a neoplastic disorder would be high. Having said that, though we see that cystic lesions are more likely to be goiters, you need to remember that some papillary carcinomas can be cystic. And these are some of the rare things which you would like to incorporate in your flowchart or in your algorithm, because these can be atypical presentations. And if you don't know it, that may easily lead to a misdiagnosis. Now, why am I discussing a lot about clinical history and clinical presentation? I would draw your attention to a paragraph from Rosai and Ackerman's Surgical Pathology, where Dr. Rosai remembers his first experience in an Ackerman case conference. He initially had thought that he had entered the wrong room because of the thorough discussion of clinical history and imaging studies that was taking place. And Dr. Ackerman used to discuss the entire clinical history before even starting to look at the slide. And Dr. Rosai wants to kind of maybe send an important message to people like me and other young people who are into pathology training that although we have started depending on the recent technological advances, the age old time tested method of clinical pathological correlation is here to stay. The next step would be cross examination. Now, cross examination certainly involves a detailed description of what we see, but ultimately it boils down to the 2S and the 2C, which is basically for the size and the shape and for the color and consistency. And so your algorithm or your diagnostic flow chart should include some relevant cross examination findings which could lead you to a particular diagnosis. For example, when you are evaluating a renal tumor, if the tumor is golden yellow, you are going to think of a clear cell RCC. If the tumor looks gray white, is extremely friable with some papillary fronts, you are going to think of a sort of papillary lesion. And at the same time, if it is mahogany brown, you are going to broadly think of an oncocytic lesion. The next step at this level would be to know whether the lesion has a central scar or it doesn't have a central scar. Because if the lesion has central scar, you are going to think of oncocytoma or chromophobe renal cell carcinoma at this stage of the diagnostic process. If you see a posterior fossa tumor, as we discussed previously, the age and the site are extremely important in CNS tumors. So now you know the site. The next step would be knowing the age, because essentially knowing if it is a pediatric age group tumor or an adult age group tumor would help you to think of different set of lesions. If it is pediatric age group tumor, the commoner lesions like pilocytic astrocytomas and medulloblastomas would come in mind. And here is where the radiology would help you. If you are seeing it as a cyst with a mural nodule, your index of suspicion for it to be a pilocytic astrocytoma would be higher as compared to medulloblastoma. Obviously, in this case, it would not be very difficult even to differentiate pilocytic astrocytoma from a medulloblastoma because they are really very different tumors on histomorphology. But this is how, even before seeing the slide, you could probably guess what are you more likely to look at. Similarly, if it's an adult group tumor and if it somewhat looks yellowish and well circumscribed, and if there's a family history of VHL, you are going to think of hemangioblastomas. Now let's take an example of thyroid gland. So essentially what you can do in the gross examination of the thyroid gland is you can arrive at a possible conclusion of which group or set of lesions are you more likely to expect. For example, if you are seeing a very large, a uniformly enlarged thyroid gland, you would like to think of Graves' disease and Hashimoto disease first. Of course, euthyroid goiters can also be uh, kind of diffusely enlarged. Uh, how would you differentiate Graves' disease from Hashimoto? If you are seeing some degree of lobulations and yellowish form appearance, you would more likely think of Hashimoto over Graves, which would have a more kind of a meaty red appearance. If you are seeing a extremely enlarged, asymmetrically enlarged gland which has cyst and hemorrhage, you would like to think of multinodular goiter. Any other lesion which looks infiltrative, which has hemorrhage and some degree of soft necrosis, you are going to think of malignancies. And if you are seeing a well circumscribed kind of lesion, you would think of solitary thyroid nodules. What would help you further in the gross examination of solitary thyroid nodule? Not really much, except if you are seeing mahogany brown color, because that would be a hint as that would suggest that you are possibly looking at a hurdle cell neoplasm. And then you would start at the third step of your algorithmic approach, which is basically hematoxylin and eosin stain kind of slide examination. There are a lot of things to see in every slide, and so you need to have a pattern as to what things would be important for you at low power, at medium power, and at higher power. So hematoxylin and eosin examination helps us solve most of the questions even now. Trust me, uh, almost all the cases that we see in our residency training and even beyond, most of the times, at least I would say 80-90% of the times, the IHCs would help you to confirm what you have already thought about. And it would be like maybe 15-20% of the rare, difficult, atypical cases where the IHCs may throw up a surprise. So as long as you're thinking on the right path on HNE examination, you are probably going to use ancillary techniques only to confirm what you were highly suspicious of. So try to describe everything that you see. This is the approach that I have used for myself during my training. Uh, every year, with every revision, certainly the reports that go out are becoming very brief, are becoming very pointed, which only give a diagnosis along with the relevant clinical and prognostic factors. However, for us to train our eyes well, I think it's extremely important that we describe each and everything that we see, even if we are proven wrong later. It's important for us to learn and in the process of training. So at low power, the first question that you should try to answer is, are you actually looking at any pathology? I think being living in a pathology world, we tend to forget sometimes that things can be normal too. And after that, you really need to answer, does it look neoplastic or non-neoplastic? And if it is neoplastic, you need to look for hints which would suggest that is it benign or is it malignant, like necrosis, circumscription, encapsulation, and cellularity. Then when you would go to higher power, you would want to look at a particular arrangement of cells or cellular pattern and architecture and the background stroma and vasculature that would give you a hint to what is the lesion that you are probably looking at. And a further higher power, you would want to concentrate on the nature of nuclear chromatin, presence of atypical mitosis, and what is the mitotic count, because that would help you to grade the tumors and grade malignancies. So essentially, your workflow or your diagnostic algorithm in microscopic evaluation uh, should basically try to decide, is it just a normal tissue or is it an abnormal tissue? If it's an abnormal tissue, is it neoplastic or non-neoplastic? And if it is non-neoplastic, is it infectious or non-infectious? If it is neoplastic, is it benign and malignant? And if it's malignant, is it primary or metastatic? So as a part of the learning curve, even if you cannot arrive at a specific diagnosis, as long as you are able to classify with a considerable degree of confidence whether a lesion is neoplastic, is it malignant, and is it primary, I think you are on the right path towards learning histopathology. Let us take an example of spindle cell lesions. Now, there can be various different types of spindle cell lesions, and soft tissue pathology is an extremely difficult subspecialty for all of us to learn. Let us take an example of whether it is a nerve sheath or a smooth muscle type tumor. So we are just thinking about two subtypes here for illustrative purposes. The first question would be, are you seeing kinky nuclei? Because they would be kind of hints that you are probably looking at nerve sheath tumors. Once you are thinking in that direction, the next question I would like to ask myself is, am I seeing necrosis? Am I seeing high grade nuclei? Am I seeing any features that would suggest it to be a malignant peripheral nerve sheath tumor? If not, obviously the differentials would narrow down to the two commonest kind of benign nerve sheath tumors, and this is the time when I would look for two features. One is their verrucate body, second are their alternate hypo and hypercellular areas, and this would essentially give me an answer. Is it a schwannoma or a neurofibroma? On the other hand, when you are thinking of a smooth muscle type tumor, yes, they would have spindly nuclei and mild to moderate eosinophilic cytoplasm, and cells arranged in fascicles and whorls. So this is the time when you're thinking of smooth muscle tumors. And if you open textbooks and if you read classifications of smooth muscle cell tumors or leiomyomas, they are essentially around 15 to 20 subtypes of leiomyomas described. And then there is something known as STUMP, and then there is something known as leiomyosarcoma. What would be really clinically and diagnostically important? One, are you seeing coagulative tumor cell necrosis and atypical mitosis? Because that would be a clear-cut hint that this is a leiomyosarcoma. It would have diagnostic, prognostic, and therapeutic importance. If not, if you are possibly looking at a benign kind of smooth muscle cell tumor, out of all those 15 or 20 subtypes, I would be really interested to know, are there cells with bizarre nuclei? Because if they are present and there is no coagulative tumor cell necrosis, atypical mitosis, it is actually still a kind of a benign behaving tumor, and it is known as symplastic leiomyoma. Now, this part would be important in your diagnostic algorithm, because if you don't know that there is an entity which is named as symplastic leiomyoma, where you can really get bizarre and monstrous looking cells, but you don't have other features of LMS, it is not LMS and it is symplastic leiomyoma. This would be especially important diagnostically for all of us to know. And finally, H&E can even give you hints about the genotypes. And when you have such hints in place in various organ systems, you would try to incorporate them in the algorithm or the flowchart that you would make. For example, if it's a papillary renal cell carcinoma, you would, you would first want to find out, is it type 1 or type 2? Then if it is type 2, you would want to look at the nuclei. So if you're seeing cherry red or eosinophilic nucleoli in a type 2 papillary RCC, you would like to think of HLRCC, associated renal cell carcinoma. HLRCC stands for hereditary leiomyomatosis and renal cell carcinoma, and this is associated with the mutation of fumarate hydratase. The take home message from this slide is that yes, we have our own limitations, and there might be various places in the world where it might not be that easy to have a look at fumarate hydratase kind of mutations. So your job as a competent pathologist would be especially to be somewhat suspicious of that this could be a possibility, because this would alert the clinical team and this would also alert the patient who might opt for uh, analyzing these mutations at some other bigger centers which may have them. And finally, you would also want to observe the background stroma. There could be surprises. For example, when we learn about duodenal biopsies, yes, we move from the lumen to the mucosa. So in the lumen, you would want to look for parasites like Giardia. Then you would want to look for celiac disease, like increase in the intraepithelial lymphocytes. And you may also want to look for flattening of villi. That may also be indicative of celiac disease and other malabsorptive syndromes. And if we don't know one thing, we might tend to ignore this particular feature. You would also want to look for plasma cells in the lamina propria, because if plasma cells are totally absent in the lamina propria, that could be a hint that this patient may be having combined variable immunodeficiency. And so a duodenal biopsy may sometimes be the first hint that this patient may be having a primary immunodeficiency disease. And then the last step would be the IHC workup and molecular path. Certainly, as new trainees or medical students, we get attracted to immunohistochemistry, molecular pathology, artificial intelligence. I was also attracted, I am no exception. And all of the ancillary techniques are extremely useful. You know, they have helped diagnostically, they have helped prognostically, but it is important for us to remember that they cannot be a replacement to the age-old time-tested method of cross-examination and hematoxylin and eosin examination. So as I mentioned previously, we will observe during our training and also during our practice that these molecular techniques, these ancillary techniques, assist us in confirming what we are thinking about, and why it would be helpful for us to be a good kind of diagnostician or a good morphologist would be we would essentially have two more checks in place to decide whether we are following the right path. So we live in a world of panel of IHC markers, but we need to learn how IHC markers would sequentially play a role in ruling in or ruling out a particular diagnosis. If we tend to use a long panel of 10, 15 IHCs, which is extremely helpful, sometimes we might get caught up and confused if we don't know the logical sequence of IHC stainings in disorders. For example, let's take an example of B-cell non-Hodgkin's lymphoma, where you are essentially thinking of CLL/SLL, mantle cell lymphoma, marginal zone lymphomas, DLBCLs, and follicular lymphomas. The first step would be to do a CD5 marker. Now, CD5 is actually a T cell marker which can be positive in some B cell NHLs. And so when CD5 is positive, you would narrow down to a possibility of CLL/SLL and mantle zone lymphoma. If it is not positive, you are going to think of the other set of lesions. So essentially, this one single IHC marker is helping you to divide these lesions in two subgroups. The next step for CD5 positive tumors would be to look for CD23 positivity, because if that is positive, that would be suggestive of a CLL/SLL, and if that's negative, it would be suggestive of mantle zone lymphoma. And if CD5 is not positive, then you are going to think on other lines. You would think of DLBCL. The hint to DLBCL would be the morphology per se itself, a high-grade tumor which can have significant pleomorphism and atypia. If you are seeing cells which have somewhat kind of indentations of the nuclei and nuclear grooving, and you have translocation 1418 that's positive, you may want to think on the lines of follicular lymphoma. And then BRAF mutations and CD25 and 103, and of course the clinical presentation would help you think of marginal zone lymphoma. So this is essentially a multi-step or a multi-pronged approach in any IHC evaluation of any organ system that may be helpful. Let's take an example of a case of breast carcinoma where you are thinking, or the clinicians are suspecting that this could be a lobular carcinoma. As we all know, this cohesiveness of the tumor cells and arrangement in a single file pattern would be suggestive of the tumor likely to be lobular carcinoma. And the first step that you would want to do is E-cadherin, because if there is loss of E-cadherin, you are going to think of a lobular carcinoma. Now the catch lies when there is some retained expression of E-cadherin. You may have observed in your training that there are some tumors where you feel the cells are discohesive, the cells are arranged in single file pattern, and when you do ECAD, it looks kind of weak or kind of not, you can't interpret a lot from it, but it is definitely not dead negative. And so this is the step where you would want to do a P120 catenin, because if P120 catenin shows cytoplasmic stain, it is a lobular CA, and if it's membranous, it's not a lobular CA. So this slide would essentially try to demonstrate what I have been saying in this talk, that HNE and ICs have to be used together to arrive at a best probable diagnosis. If we would have only thought of loss of expression of E. cadherin as a signature of lobular carcinoma, although we might have observed features suggestive of lobular carcinoma, because you see some weak expression of E. cadherin, you may not think on the lines of it still being a lobular CA if you don't know that there can be some lobular carcinoma tumors which have weak expression of weak adherin, and doing a P120 cadherin stain would be extremely important in such cases. Now remember, classifying breast cancer as lobular or ductal may also have diagnostic and therapeutic relevance. So this classification is extremely important from the clinical perspective. So I try to demonstrate the use of these algorithmic processes in histomorphology or in histopathological examination, a quick take on whether they could be useful in clinical pathology. I would try to demonstrate how or what would be the philosophy in a one clinical pathology algorithm, which would kind of tell what would be the important factors while constructing it. For example, let's take an example of an approach to diagnosis of malaria. Step one would be the region, because if you are in the US or on the western side of the hemisphere, you would think of babesia rather than malaria. Like in US, it's extremely rare to find malaria as compared to the Asian and the African continent. But if you're seeing an intraerythrocytic parasitic infection in Asia, in India, yes, you would most likely think of malaria first. And the take home messages, flowcharts, and algorithms would have to be modified according to the circumstances, according to the geography, and according to the disease prevalence and incidence in that particular area. Now, if you are in India and if you are thinking of intraerythrocytic parasites, you are thinking of malaria straight away. What would be really important here would be to design an algorithm that would help you diagnose Plasmodium falciparum with the best possible accuracy and precision. The reason is falciparum, as we all know, can cause clinically serious complications, and it would be extremely important to diagnose it accurately and correctly to prevent those complications. So the take home message from step two would be, when you would construct an algorithm, you would try to ensure that there are multiple checks in place which would kind of make you think or make you suspect of Plasmodium falciparum and have a high degree of suspicion for this particular species given its clinical kind of importance or relevance. And then the third would be the Swiss cheese model. So as morphological diagnosis can be tricky, so we have Plasmodium vivax and Plasmodium falciparum, which can have totally different features. Uh, for example, the size of the red cell, how many number of tryphocytes are present in the red cell, what is the thickness of the ring opposite the point. So all these factors would be differentiating, but no one factor would be kind of diagnostic of one particular species. And this is where a Swiss cheese model would be important. You would try to incorporate many checks in the algorithms, which will lead to the most probable diagnosis. And the last step would be, don't forget the rare species. And this is an example, a quick example of one such algorithm that I made. So as you know, the first step that we discussed was having a high degree of suspicion of malaria. And then if you are suspecting malaria already, you would have multiple checks in place which would make you suspicious or make you think of falciparum. For example, headphone appearance, then the size of the RBC if it is normal, then if you are seeing multiple RBC, multiple tryphocytes, and then if you are not seeing any thickening of the ring opposite the chromatin dot. So this is how a similar kind of concept that we use in anatomic pathology may probably be useful in clinical pathology also. The next things that are extremely useful are checklists. So what is the difference between an algorithm and a checklist? An algorithm is a logical sequence that leads you from the clinical history to a diagnosis, and checklists are basically kind of data points or data sets which you must go through when you evaluate any kind of organ system. The goal of the checklist should be to ensure uniformity and to avoid omissions and errors. Has this approach worked in medicine? you might or you might not know this. Certainly, yes. The most important example is a surgical safety checklist, which was created by World Health Organization. If you see, some of the questions in this checklist look very simple, look like some things which, every kind of clinical team or surgical team will want to look at before starting at any surgery. But this checklist came out of an interesting concept which was spearheaded by Dr. Atul Gawande. He has described it in details in his book, The Checklist Manifesto, and it kind of resonated a lot of ideas that I have. Um, he and his team kind of conducted research using this checklist at 8 hospitals around the world. And what was surprising was they found like there was a nearly 30 to 35% reduction in the perioperative mortality and kind of clinical or infection complications. And this was after which the WHO accepted the surgical safety checklist, and they have been kind of encouraging its use in the ORs around the world. So these are some of the checklists that I tried to create kind of during my training. There could be a checklist for bone marrow examination because there are multiple points that you would want to look at during your bone marrow evaluation. There are multiple points that you would want to look at GI biopsies or duodenal biopsies. And then there would be a final checklist which you would want to follow when you are evaluating any slide. And these kind of checklists would help you, to uh, probably avoid any error, or probably not have a blind eye to something which you are more likely to miss. Having said that, are these really good checklists? According to me, they are not really that good. The reasons are, there is a difference between good checklist and the bad checklist. The first important thing would be, what is the time that is taken to read the checklist? If it's more than a minute, trust me, no one is going to use it beyond a point. Secondly, it would be the number of words. If your checklists are pretty crowded, if they lead you to answers which are descriptive, they are perhaps going to add more to a confusion. And the third would be, what is the clinical, diagnostic, or the therapeutic relevance? So they should try to optimally use space to include those factors which would be extremely important diagnostically, clinically for the clinical team, and may perhaps give you hints of a possible use of a therapeutic drug which might be useful to a particular diagnosis. So the essential goal of checklist should be to help to prevent near miss. And taking inspiration from that, I modified this checklist into this. Now, what's the difference between this one that I made and this? You can certainly see there are lesser words. It is more focused on what is extremely important for a diagnosis. Most of the questions lead you to an answer in the form of a yes or a no. And the total number of points in the checklist sum up to 20 rather than 22 in the previous checklist. I believe that during our training and even during our practice in pathology, these kind of checklists may be useful for us to do a better job and for us to kind of do the best possible job for the clinical team and the patient as a whole. Having said that, the last slide, what are the limitations of this approach? As I said, and there are many seniors who are panelists currently, uh, they might have seen very rare tumors, they might have seen very atypical presentations of various diseases. And so as we know that lesions may not read books, there may be very rare atypical presentations, and so these kind of lesions will not follow the algorithm that you are trying to construct. All the relevant points may not be accommodated in one checklist. For example, when you are evaluating CNS tumors, yes, there are 10, 15, or 20 different things that you want to really look at. But everything cannot be incorporated in one flowchart or one algorithm. And you are trying to gauge and kind to judge, just like we have risk benefit ratio in taking clinical decisions. When you are making algorithms, you are trying to decide which one single thing would give you the most important or most relevant information, and in the process you might have omitted a few others which may be important in one particular rare scenario. And that is why when I make and when I share this kind of algorithms, I try to encourage each and every kind of resident, each and every medical student to make their own. They can be different, they can have differences. Some of them may not include points which are universally accepted, but may include points out of sheer observation during your training. And so you should try to use this as a blueprint and as an attempt to standardize your own process of kind of being a diagnostic pathologist. So in short, you should use them as a guide, as a diagnostician or a trainee, but you should not allow them to master you. That's all which I have wanted to present. I hope this presentation would be useful to anyone who is new to pathology, the medical students and the pathology trainees. Thank you.
Thank you, Pranav, for an
Thank
excellent,
you.
most precise, lucid presentation with a lot of illustrations and flowcharts. And I would say that my colleagues here would definitely agree with me that your deliberation has been very, very good, and probably it reflects your passion for art of algorithm in pathology. And personally, I enjoyed it because you started with the examples of neuropathology and endocrine pathology, which is my interest, and I most enjoyed it. Thank you so much. I have some questions and queries.
Yeah.
If time permits, I would definitely like to discuss. Meanwhile, I would request others also to be ready with their comments and questions. I do not see anything in the chat so far from the audience, but can I just say that we all know that these algorithms in pathology, particularly, are being practiced in tumors mostly. And from friends that I learned, friends in US, I learned that many of them, they practice these algorithms while routine reporting, etc., etc. Um, Breast tumors, lymphomas, CNS
Hmm.
tumors, they are the genitourinary tumors. They are one of the good examples. And you have touched the my question and my query is just regarding, you very nicely touched with the non-neoplastic pathology and gave examples to us about celiac disease and malaria, which is very good. I am just curious to know, are you aware, are you practice, or do you know about any other non-neoplastic pathology where it is extensively, where it is seriously practiced, so that on Indian side we could be more educated about it, and we can start. So that is one question, but I have plenty of others also. So
Yeah.
I have you have stimulated the mind, and I'll ask you first.
Yeah, sure. Thank you. Yeah, I mean, in the US, the one difference that I noticed is we have a CAP cancer protocol template. I think it's available free of cost, everywhere for anyone around the world. And I'm sure a lot of premier institutes in India also have
Yes.
their own kind of checklist. So these kind of protocols, it's mandatory for every institute to follow it. Otherwise, you risk the loss of accreditation. And so this kind of brings some uniformity to the kind of way of reporting, I think, across the country. I don't see any kind of flow charts as directives for a diagnosis. Rather than that, there are like data elements which you have to fill in, and without which your report cannot be complete. And as I said, that leads to a lot of uniformity. And sometimes, if we might forget something, or because evaluation is extremely complicated, you might forget to mention something in the report, those data elements kind of act as an automatic check. uh, as regards non-neoplastic pathology, I haven't yet come across any kind of mandated flow chart for us to follow.
So
Dr. Pranav,
I
please
think
switch on
then
your, please start your video, Dr. Pranav. Please start your video.
Okay, yeah.
so
Yeah.
Pranav, then I think,
Our
yeah,
panelists must see you. Yeah.
yeah,
Can you see me now?
yes, yes.
Yeah.
Yeah. Thank
Sorry.
you so much.
People like to see your nice face. So, so no, okay, that means, I mean, as you said that you are not really aware of any definite protocols for non-plastic pathology. I think it's a challenge for the Indian young pathologists to develop those. We have a lot of non-neoplastic diseases. The other thing which I was curious to know is that are these algorithms being used, particularly for neoplastic pathology in US, and in your experience, what is the overall accuracy for? Is it accuracy for the same, say, for example, breast, ovarian tumors, thyroid tumors, or is there a range? And if a pathology student in India or a person like me has to start,
Uh-huh.
anybody in the medical college, which one should he pick up, or which three you would recommend those things to
So
Indian population?
I would highly recommend the cap cancer protocols for sure. The reason is they are not only data sets. If you see the PDFs which are easily downloadable, they have clear explanations below the data sets where they explain why that particular data element is incorporated in the report. One, what is its kind of relevance diagnostically and clinically? Two, and thirdly, how would you want to look at it? For example, if the data element has a concept of tumor budding in GI pathology, they would explain you like what is tumor budding and how would you want to grade
Yeah,
tumor
that
budding.
is all right. That's all right. That
Yeah,
is a general statement. My question is very focused. My question
yeah,
is that first question is that, say for example, you take to take examples of three. Say for example, lymphoma, GI malignancy, ovarian. Uh, is there data available to say that the accuracy of these algorithms would range from this or this or these? This is the, in your experience, which one is the first that one should at least start at smaller levels here?
I am not aware of any data about
Okay,
the accuracy or something like that.
okay.
I just know that they are, I mean, they are mandated some of the cancer protocols, and that's what we follow.
Yeah, but now why I'm saying so is that
Yeah,
contrary to the belief that maybe India people are, I can just say that many of us believe that the smaller centers in India, they do not follow this. I think India has changed quite a bit in recent times, and even if a center is small, and even if they don't have facilities to do in-house things, many oncologists or many clinical clinicians or even pathologists, they are outsourcing things, and
okay,
India has really moved out,
yeah,
moved up
yeah,
quite a bit in recent times, and therefore that's why I'm asking that. I mean, if one has to, since there is a big audience here, I mean, very most distinguished pathologists sitting here, so wanted to get some feedback. The other thing which I wanted to know from you was, or maybe don't take it criticism, but
yeah,
this is very good art of algorithm. But I think, as you have yourself said, that we practice it every day in our
yeah,
routine reporting and our slide sessions, slide seminars. So
right,
every teacher says, okay, these are 3 points
yeah,
failing this. And
yeah,
you very nicely highlighted the age and location and age and imaging and say bone tumors, age and location and neurotumors. But I can say that the algorithms are basically a documented thing. So now it is
yeah.
a black and white thing that you practice this. My correct me if I'm wrong. My problem with that is that could our trainees get swayed by this, that okay, algorithm is there, so would their minds be slightly blunted? One thing, because I firmly believe that these algorithms are helpful, but they are not conclusive tools. And you probably in your last line in your presentation said that. So, are there any ways to take care of those things? Because in our trainees also, they would follow. Okay, they immediately open their notepads and okay, this. But I think what are the ways to probably uh, check this kind of tendency?
Yeah, I totally agree with you because, uh, as I said, like sometimes tumors don't read books, and it should not become like you would become robotic if you start using this flowcharts or algorithms. So I think there's a thin line. There are some good points, as I said, like once you use them, like suppose you are evaluating 20 tumors, and if you are using that particular checklist 20 times, and subconsciously that thing gets incorporated in your brain, that how you would want to kind of format a report for a particular system. But yes, so as I said, I think there has to be orientation about how to use them, probably from seniors and from experienced teachers, and everyone should be aware of what are the limitations. Like if you see the way I share them, I clearly have stated that they are just educational. They may There may be some differences and there may be some atypical presentations. They would to some extent help us to bring uniformity in
Yes.
training, especially I believe,
Sure, sure.
because the training, it would be different. Again, different people would have different perspectives. Everything would be useful, and in this scenario, I think some uniformity would be good to achieve.
Yeah, yeah, but that is what most medical pathology teachers should remember, that it is for the uniformity and it cannot
Right.
replace anything. So I think
Absolutely.
I can give you feedback from the chats that people
Yeah.
have said that your lecture is excellent and good presentation.
Yes.
So that is okay. And I request other panelists if they have questions to answer. I have I have actually a few more observations, but I would request others to make comments.
Okay.
Yes, others.
Can I
Yes,
Yes,
yes, please.
comment?
Yes, yes,
Okay.
please go ahead.
This type of algorithmic approach was there, in fact, in all subjects. Like I
Yes.
practice liver pathology. So there are four items you should always see. Whether there is architectural distortion, then you see whether portal tract based disease, then you try to see whether there is a in this cirrhotic background, whether there is any malignancy. And ultimately, we try to put in a, if there is a chronic liver disease, whether it is due to chronic hepatitis B, C, or a autoimmune hepatitis, based on certain characteristic features. So it is not only there in the neoplastic pathology, non-neoplastic pathology, I think it was long time it is there. Even in kidney biopsy interpretation also, there is an algorithmic approach. How do you go from glomeruli to interstitium to tubules to vascular? So everything is there. So I think now the CAP protocol has brought this. That is, of course, another issue altogether. What you should report, are you have concentrated on how algorithmic approach can help us to reach a certain close to the diagnosis. So non-neoplastic pathology has got always some sort of a approach.
Yeah, sure, sure. I can. Thank you, Dr. Shim, for giving your contribution in this deliberation and for your comments. Yes, I can. I mean, I can add to that that in real neuropathology, which is non-neoplastic, neuropathology is basically tumor neuropathology is only 10% of neuropathology. Rest of it is non-neoplastic. The actual neuropathology is non-neoplastic. So there are variety of kind of algorithms and a variety of those flow charts that are used there. But now I have another personal query,
Yeah.
and that is around about these the currently WSI, that whole slide imaging,
Yeah.
etc., etc. We had acquired a Philips digital scanner, and we are using it. But I think we are using it only for archiving and for other reasons, not for the routine reporting, which is actually the idea. So we have to
Yeah.
go for that. But when these people, they come to us for demonstration and for telling us all those things, and actually there you can have those all those algorithms being applied and all. So they tell us, okay, buy this algorithm, buy that algorithm, and so on. And then one of the terms which one somebody used was deep learning algorithms. So I do not know, because I don't have much knowledge about this. So do you know anything about what is, because they tell you buy this one, buy this thing. So I don't know whether we should go for these things. So segmental something, some pathology imaging segmentations, and so can you tell us something about it? If
Yeah,
you
so I mean, I can only say that as you mentioned, everything is. I think a lot of studies are being done on artificial intelligence, especially in US. You know, some research institutes are trying to study various aspects, like whether you would be able to report melanomas or something others. But I haven't come across, any particular knowledge that it is being routinely used for diagnostic purposes. It is still under experimental stage. Yes, institutions are having grants and they are kind of studying it. Research papers are being published, but I think it's at the same level the way you mentioned.
Okay, okay. So anybody else who wants to make any comment? Um,
Siddharth, I think Siddharth wants to say something.
Siddharth, please go ahead.
Siddharth,
Siddharth, please go ahead. Dr. Datta Gupta,
unmute, Siddharth.
Yeah.
unmute
Can
yourself.
you hear me?
Yes, yes.
Okay, okay. First of all, I think I must congratulate Pranav for an excellent lecture.
Thank you.
Undoubtedly, in the time allotted, he has covered this one really outstanding. I think there are two or three things we often confuse algorithm with data sets and combine both. Actually, data set is different. It is a collection of information systematically for a specific purpose. For example, data set for breast cancers. So what all information should be there in the report? Algorithm, on the other hand, which is taken from mathematics actually, is a defined sequence to arrive at a solution.
Yes.
So you have to do this, that. And as Dr. Radotra said, we always use algorithms in the back of our mind.
Yes.
Right,
Each one has, I'm sure, whether you have it in paper or not.
right.
But it is good, I guess, for the students in the beginning so that they don't miss any point. For example, if you see a granuloma, are you seeing a granuloma? Is it confluent? Is it not confluent? Is there caseation? Not, so something like that, you know. So that's why it tells a person almost systematic, like clinical examination. You have to do the inspection, then palpation, percussion, on what auscultation. So something like that. So that way it is helpful. And nowadays these are being extended to artificial intelligence and
Mm,
what you said in the end, that is the nucleus big, small, is it more dark, less dark? So like that the computer itself will, hopefully someday they are saying that, but it will not replace human beings obviously. So that way I think algorithms are in a
Right.
way partly helpful for training, partly helpful. It is helpful to ensure that you follow a certain systematic way of examining slides, or even clinical pathology. You do this test, then this, and whatever it is.
yeah.
That way it is good. And I think he did full justice and
Yes.
covered it excellently. So,
Thank
Uh,
you. So I
the-
totally agree with
yeah.
what you said, Doctor. Like all this started in my years of training in India, and that basically started because when I got exposed to histopathology, it was like, oh my God, how am I going to navigate through this, and how am I going to learn 29, 30 organ systems in 2.5 years or 3 years? And that's when I started creating it. And as you rightly mentioned, yes, so the cap protocols are they are mainly like data sets. So no particular organization or body would authorize or would recommend a flow chart. I think for the limitations that we discussed at the end, like you cannot follow them without thinking what is your own impression or what is your own diagnosis. So yes, I think these are mainly educational, and I think this would help us to kind of develop a uniform level of competency in histopathology out of training for all pathology trainees.
So anyway, I think I would like to thank Dr. Datta Gupta also for his comments, and I think his advice is always a welcome thing. So I cannot agree more with him in thanking Pranav for a
Thank you.
wonderful lecture, and it was personally a pleasing experience to see you virtually and
Thank you.
listening to you. So I think Asranti, I think it 8 o'clock. So shall we stop or okay?
Yes, just comment from other members, senior, if they want to do. And I will only say it was really a very nice and informative lecture. And what I personally feel that when PGs start their training, even nowadays, when they are presenting seminars, so many, so vast knowledge is there, and if they want to learn everything, then it is very difficult. So usually, whenever they are presenting seminars, I say, you describe everything, but in the end, present a flow chart or an algorithm gist of that seminar, because you can only remember that. If you remember that, then you can further move on. So that is very important when the PGs, they are coming in their first year, their second year. Besides, still we are having that theory type of papers where they
Yeah.
have to write down those long answers and diagnoses and that. So this type of flowcharts and algorithms, they help them in retaining the knowledge and answering the questions, because the long or lengthy paper, if they go on writing everything, they cannot finish it in 3 years. So such flow charts, or you can say algorithms or tables, they help them. So I had asked them, and they made a practice that whenever you are presenting seminars, learning anything, make a chart with you for your convenience. There may be the other like CAP guidelines and everything, but for their convenience, as per their, they can make a protocol for themselves through which they can learn and further move forward and learn. So this such type of things really help them in retaining, because otherwise pathology is such a vast subject, and with ever changing, and every day there is addition of a new molecular techniques, new
Yeah.
in immunohistochemistry markers. Every day we are getting new markers, so it is very difficult. So when they make these things, this helps them in retaining. And as we know, in any curve, at least these algorithms of flowchart, they cover the main middle part. Yes, the left and right arms, they are there, and we have to go beyond this algorithm for them. So really very nice lecture, Pranav,
Thank
and
you.
very informative. And I think it is very important, and each and everybody, at least for their personal use, they can develop these flow charts and algorithm which can help them in long life. Any comment from Dr. Mohanty, Dr. Parija, and other senior members? Oh, yeah.
Dr. Vasala,
Yes, Master.
the lecture is very nice and informative for everybody. But what I think, this algorithm word actually came after from this IT use, information technology people. They more they use, and earlier this word was not in use in pathology. What you mentioned about a flow chart and other things. So step by step, actually, is a algorithm is moving step by step to arrive at the last point. So that is the thing. I feel this flow chart or this step by step moving, it should be compared to the rituals performed, the ritual rites, when the worshipping and doing arati. So they follow step by step. So accordingly, we must stick to these uh, algorithm steps and to arrive in the diagnosis. However, one should be very sincere for this observation and making these things, starting from the clinical, starting from this gross exemption, starting from the existence slides, and so on and so forth. So once you stick to this flow chart, but upstairs, or algorithm, steps of algorithm, so that will help us to arrive in a proper diagnosis. Anyway, this is Dr. Pranav has done his duty very well. There is a concise lecture, and it is a very nice lecture. It will help the postgraduates, trained pathologists, also seniors like us, so learn many things. And this, thank you, Dr. Pranav.
Thank you.
Dr. Pranav, for a very nice talk. At the same time, this is helpful from the training to start to professors and also senior pathologists in the state and outside. So this is very good talk. Nice. Thank you very much.
Thank you.
So thanks, Dr. Pranav.
Thanks.
I really never knew it will be so good. And for the beginners, it will be really...
Why? It's very good.
Yes. So I didn't know Dr. Pranav, just I came to know about him from the internet. I saw that topic, then I thought he can do. I got the number from Dr. Pradeep.
Oh, okay.
Then I contacted him.
No, his talk is in internet, is there.
Yes.
His talk.
So very nice, and many have given also. They have, like Radotra sir told, many have given their excellent talk, informative talk. So thank you all. Should we
Thank
end this
you.
meeting now, madam
Yes.
and sir?
Yes, yes, yes.
Yes.
Thank you.
So let's end.
Time is there.
Good night. Thank you all. Yeah.
Thank you, Shanti. Thank you for
Everyone, all the senior
thank
members for attending. Thank you.
Thank
I
you.
would, I would,
Good night.
Good night. Be safe. That is the main thing.
yeah, is it photograph or what?
Over.
What is happening?
Over.